This study was conducted to clarify the relationship between E-cadherin expression on tumor and lymph node metastasis, as well as its prognostic roles in resected non-small cell lung cancer. 249 patients who underwent surgical resection, stage II, were examined. Paraffin-embedded sections of the primary tumors in all cases and of the metastatic lymph nodes in stage III disease were stained with a monoclonal antibody against E-cadherin. Decreased expression of E-cadherin correlated with pathologic stage, tumor size, lymph node metastasis, and histological grade. The 5-year survival rate of E-cadherin negative patients with stage II disease was significantly lower than that of E-cadherin positive patients. Multivariate analysis in stage II disease indicated that E-cadherin was an independent prognostic factor. In the patients with clinical N0 tumors, the frequency of pathological N2 tumors was significantly higher in cases where the primary tumor was recognized as E-cadherin expression negative than in cases where the primary tumor was recognized as positive. Decreased E-cadherin expression showed correlation with presence of lymph node metastasis in resected non-small cell lung cancer and with the prognosis of patients with stage III disease. The standard treatment for early-stage non-small cell lung cancer is surgical resection. However, many patients are inoperable due to medical comorbidities. 32 medically inoperable patients with early-stage non-small cell lung cancer were treated with three-dimensional conformal radiation therapy between January 1991 and December 2000. The median dose was 70.2 GI, and the median follow-up time in survivors was 30 months. The 2-year actuarial local control, overall survival, and cancer-specific survival rates were 43%, 54%, and 57%, respectively. The 5-year actuarial local control, overall survival, and cancer-specific survival rates were 43%, 33%, and 39%, respectively. This report suggests that local control is improved with high-dose conformal radiation therapy when compared to other institutions' retrospective experiences. The semaphorins are a family of secreted, transmembrane, and membrane-associated proteins initially identified as causing the repulsion of nerve growth cone guidance. However, subsequent experiments have demonstrated that they can induce retraction in non-neural cells and affect the development of non-neural organs. 2 related secreted semaphorins, HEMA3F and SEMA3B, were isolated from a recurrent 321.3 homozygous deletion region in small cell lung cancer, SCLC, cell lines. Moreover, a functionally related molecule, roundabout/DUTT1, was identified as the target of a more proximal chromosome 3 deletion, also involving SCLCs. Based on current data, it is likely that the loss of these semaphorins or roundabout may affect cell migration, metastasis, and apoptosis. In addition, receptors for the secreted semaphorins, neuropilin-1 and neuropilin-2, have been shown to function as coreceptors for a subset of vascular endothelial growth factor, VEGF, isoforms, and related growth factors. Since semaphorins and VEGF bind antagonistically to neuropilins, their loss is likely to facilitate angiogenesis. In lung cancer specimens, antibody staining against SEMA3F has been shown to correlate with stage and histologic subtypes, with more aggressive tumors showing increased VEGF and decreased SEMA3F staining. This review is focused on a basic understanding of these pathways with an emphasis on their role in lung cancer. In order to increase confirmation, the target volume is split into a cranial and a caudal part. Both volumes are planned and treated completely independent, using half-collimated fields to prevent over- or underdosages in the junction plane. In comparison with conventional techniques, the irradiated volume of normal ipsilateral lung tissues at dose levels less than equals 65 GI, less than equals 45 GI, and less than equals 20 GI can be lowered to values of 37%, 49%, and 86%, respectively. Other organs at risk, such as the heart and esophagus, can also be significantly spared. From December 1995 to December 1999, 54 non-small cell lung cancer patients were treated with doses greater than 80 GI, mean 86.3 GI, range 80.1 to 94.9 GI, International Commission on Radiation Units and Measurements. 22 patients were stage I or stage II, and 32 patients were stage II. 15 of the 32 stage III patients received chemotherapy before radiotherapy. Only one patient showed a transient grade 3 toxicity, pneumonitis, and at the time of this review, no grade 4/5 toxicity has been observed.